But now I want to switch gears and I want to talk about the disease. And okay, so tick bite. We already agreed that this is a very tiny little tick. And this is usually the nymph. Remember now, this is the tick in the summer. A female, which we usually see in the fall or in the early spring, can transmit as well, and it's much larger. And at least from that perspective, it's easier to know that you have a female on you and get rid of it than to get rid of a nymph, which is so very small. And you can see it here in the context of a finger. So about 70% of all patients with Lyme disease, and this is worldwide data. And I stress that this is the natural history of the disease. This is an untreated patient. There is a localized cutaneous lesion which is called Erythema migrans. Erythema migrans basically is a term that means erythema is a red lesion or cutaneous red lesion, and migrans is Latin for something that migrates, that enlarges. So one hallmark of the Erythema migrans is that it gets larger. And let me add that 70% of the patients usually have the Erythema migrans or have the Erythema migrans. The other 30, one would have to argue that they actually never had or never noticed an Erythema migrans. And you can think about how this happens very easily. Suppose you have it in your scalp, or suppose you have it in the back of your body and you're not looking at yourself constantly, or nobody's looking at you from that perspective. You could easily not acknowledge the fact that you had an Erythema migrans. Having said that, erythema, well, I will come back to this. And then this is what's called localized disease. And then there's the disseminated disease. A very large part of the Erythema migrans patients resolve on their own, even without antibiotics. And very large part of these people do not go on to have disseminated disease. But those that do means that the spirochetes have now moved from the skin where they're localized and become disseminated. And in the case of Lyme disease, they can invade the nervous system, whether it's be the central or the peripheral nervous system, the heart tissue, and the joints. These are the general percentages of occurrence. These are probably a little bit inflated because we know now that cardiac disease is a lot less than that. But in terms of Neuro Borreliosis and in terms of arthritis, for those that get disseminated disease, these are fairly accurate. And then, just to remind you again, percentages refer to untreated patients. So Erythema migrans, it's about 7 to 14 days after infection. 70 to 80% of patients begins as a small macule or papule at the site of the bite. Sometimes it is very obvious where the tick left over a little scar. Sometimes it's not. And there's a bullseye rash. There's another type of rash which is associated with a new Borrelia that happens in the southern state, and this is Borrelia stari. And the associated symptoms with the Erythema migrans can be malaise, headache, fever and chills, myalgias, and arthralgias. But I should have here as an E, nothing. A lot of patients have Erythema migrans that have zero accompanying manifestations. So simply it appears as a localized lesion without anything else to go along with. Patients that have an Erythema migrans and know and recognize an Erythema migrans are lucky because they get themselves to the doctor, and the doctor prescribes the correct antibiotic, and more often than not, that will be the end of this disease. It will end and abort at the skin level. Complicating the issue, however, is the fact that the morphology of Lyme disease, of Erythema migrans is not, it's not always exactly the classical bullseye rash. For example, here, is the little scar in the middle. This is the remnant of where the tick bit, and these are concentric rings. This is fairly traditional. If we wanted to take a skin biopsy and we wanted to see spirochetes in the skin, we would take it at the leading edge of the lesion. And as the lesion expands, usually thought that the inflammation follows the expansion and the dissemination of the spirochetes. In this particular patient, this one came from Europe. It's a red, unrelieved red, not concentric rings cutaneous lesion. Sometimes they're not round. Sometimes they can be, like in this particular case, they're triangular. Sometimes they're very faint, not very, they don't stand out very much. And sometimes they're truly, truly awful, such as in this particular patient. This, of course, usually it's put in for effect. This is not what you would expect in your ordinary run-of-the-mill erythema migrans. In fact, I think every researcher in Lyme disease always shows this one picture because I think it does illustrate the point that it can be pretty nasty, but it's not what you would expect normally. If you have the erythema migrans in a confined space, such as the earlobe, this is what happens. It doesn't seem to extend beyond the earlobe, and this name here, lymphocytoma, is a name that was given in Europe to this, and nobody knew what it was at the beginning of the 20th century. And while I'm talking about Europe and talking about Lyme disease, the Lyme disease as we know it today was pretty much defined and identified by the Yale group in Lyme, Connecticut in the mid-70s. However, there is a huge European literature that talks about erythema migrans and a lot of the neurologic manifestations and even arthritis in Europe, in Germany, in France, and in Scandinavia. The one thing that did not happen in Europe at the beginning of the 20th century is that they did not aggregate all of these manifestations. But the entire history of Lyme disease was written in Europe 60, 70 years before the Yale people came into Connecticut. But what they did, and this is no small feat, is that they put it all together into the one thing that we know cohesively as Lyme disease. And this term here actually came from Europe, but it's now applied to this particular manifestation here in a reduced space. Sometimes they, for those people that know dermatological dermatological lesions better, this looks like a fungal fungal lesion. And then in patients of darker skin, sometimes are very much at a disadvantage in the diagnosis of rashes and erythema migrans. But in the case of Lyme disease, it appears that this is not the case. And in patients with darker skin, there is enough of a contrast that this can actually be picked on a clinical basis. So if you remember the other photograph that I showed at the very beginning and talked about localized and disseminated, it is very important distinction. Localized disease is treated with antibiotics orally. Disseminated disease is treated with antibiotics parenterally, intravenously mostly. So question is, or a very early question, was this 2 tick bites? Or is this this is the original tick bite with the erythema migrans and the tick bite here, which you can see here. And this is another lesion that is a satellite of this one. It is anticipated that multiple erythema migrans represents a manifestation of disseminated disease. So you would treat this in the same way that you would treat any other type of disseminated disease within the nervous system, the heart, or the joints. And here's another case of multiple erythema migrans. And now I want to again switch gears, but what I think, again, take-home message is there are many different shapes to Erythema migrans. There's the classical bullseye, and if you have that, that's great. If you don't, you cannot say, well, I don't have it. And by and large, the diagnosis of Erythema migrans remains a clinical diagnosis. There's no antibody formed at the time that the Erythema migrans appears. So the doctor needs to be fairly certain that they're identifying an Erythema migrans lesion. There's Neuro Borreliosis. This is the affectations of the nervous system with Borrelia. The very most common of the manifestations is a lymphocytic meningitis. Self-limited, but it is the most common here in the United States as well as in other parts of the world. There is a condition known as Bell's palsy, which is a seventh cranial nerve palsy. Next is meningoradiculitis called Banworth syndrome. Banworth is a German doctor that actually identified this before World War II. And nobody ever knew that he had written this because he wrote in German and the war came, and by the time people discovered Banworth, it was a little bit too late. And then peripheral neuropathies, encephalitis, and chronic encephalopathies. These two have been described, but they're extremely rare. This is the one that is most common, and this second most common is Bell's palsy. And then the hallmark of Lyme disease, well, no, talk about the one aspect of Lyme disease that's a little scary. It's about 1% of the patients develop conduction abnormalities of the heart. This is what you would expect to see medically. And here, I don't know how well you can see this. Again, I stress the fact that this has nothing to do with a photograph. This is the fact that Borrelia is such a pain in the neck, and it's so thin. Here's a Borrelia lying within the fibers of the heart muscle. Here's another one as well. So all of this is usually in response to the Borrelia that have taken up residence within the fibers of the heart muscle. And then there's myocarditis and pericarditis, both conditions that are known to be rare in terms of Lyme disease. And then Lyme arthritis, and this was the first that was actually described way back in Lyme, Connecticut. You all probably know the history here. Was discovered after investigating an outbreak of juvenile arthritis in Lyme, Connecticut. It has arthralgias and arthritis, but most important, it has very frank monoarthritis in the large joints with a marked preference for the knees. And that's one photograph, and here's another of the same thing. So I don't know how observant you've been, but all these photographs that I've been showing you, they're mostly children. And there's a reason for that. Lyme disease is primarily a disease of children, and what you have here is an age and sex adjusted graph of Lyme disease that starts with year 0 to year 90. And this numbers of cases, this came out of the CDC. Blue is males, yellow or green is female. It's a totally bimodal curve with the children accounting for a huge portion of the chart. And if you're even more observant than that, you will note that this is actually a disease of little boys. There's a very marked difference between the numbers of boys that get Lyme disease and the number of girls. And I'm not going there as to why that is, because one could argue that some of the reasons may have to do with that could be sexist or whatever, but this is a fact. And then again, it happens that males outnumber the females until we get into the older age groups, in which obviously the females survive a lot of the males. But this is the latest data from the CDC, and it spans the decade of 2001 to 2010, and it hasn't changed markedly since this was done.